think. Yeah, okay. Okay, let's try this again. Thanks for everybody's patience. All right, so like I said, we're gonna go ahead and get started here. So first, I wanted to say I appreciate everybody coming today. I know it's always a challenge to find an extra hour in our day away from our notes, away from our clients. So really appreciate everybody taking the time to be here. And I'm super excited that we're talking about this topic, right? So suicide assessment, risk management, because, as we know, this is such an important topic. It's something that we deal with on a daily basis in our work, right? Such a core part of the progress we make. Like we can't make progress with our clients unless they're safe, right? So I appreciate everybody wanting to continue to grow in this area. For today, there is going to be a part at the end where we're going to kind of go through some vignettes together that are going to be more interactive, I guess you would say. But it's totally cool to have questions throughout. I really welcome those. So I think Jack is going to be able to monitor the chat for us somewhat. So if you have questions or comments, feel free to throw those in the chat and Jack can kind of keep me informed. And also totally cool to raise your hand if you have a question or whatever that may be. We're also going to try to save some time for questions at the end. But like I said, it's a pretty jam-packed hour we're going to have. So let's just go ahead and dive in. Really briefly, I'm just going to introduce myself. So as I said before, my name's Sarah Fox. I'm a clinical psychologist. I work at the New Directions Mental Health Office in Pittsburgh. I work with adults with a wide variety of presenting concerns, so I consider myself a generalist practitioner. I also work as a clinical supervisor for people seeking licensure. In addition to my work here, I've previously been involved in work in college counseling, forensic assessment and therapy, as well as some inpatient behavioral health work. So, kind of getting started about why we're all here today talking about managing suicide risk and assessment, right? So I think in a lot of ways it goes without saying, as I said, we all know this is such a big, important part of the work we do, but sometimes really looking at some numbers can really drive that point home. So first is that 1 in 4 psychologists loses the client to suicide at some point during their career, right? So that's a huge number, right? So that means, so there's like a little over 50 of us in this space right now. So like, maybe 12 or 15 of us will lose a client to suicide or already have lost a client to suicide, right? So that's a pretty staggering number. So it's definitely something that's on our minds a lot. It's also just a huge global public health issue, right? So there was 1.6 million suicide attempts in 2022. It's the second leading cause of death among young people. So people 10 to 34. I mean, that's a huge statistic right there. We also see, unfortunately, a lot of suicides in the medical profession. It's pretty intense. There's about 130 suicides daily in the United States, and about 48,000 Americans are dying per year. So those are some pretty staggering numbers, right? So we all really, I think, we know from the work we do how important it is to try to provide the best care we can around keeping our clients as safe as is possible for us. So with that in mind, let's kind of talk about what our goals today are going to be in this presentation on suicide assessment and risk. So we kind of have 6 goals that we're going to go through today. First, we want to understand and manage our own attitudes towards suicide with our clients. That's a really important part of it. We want to understand and apply what are the risk factors and protective factors for suicide, what's relevant here when we're assessing our clients. We'll talk about developing and maintaining a collaborative and empathetic stance towards our clients throughout this safety planning process. We'll figure out what the level of risk is, what it would actually look like for us to create a safety plan together. Talk about documentation, and then last but certainly not least, we're going to talk about how we engage in our own self-care around managing our clients with suicidality, right? Because it's super, super heavy work. It's very important. It's very necessary, but it's heavy. And so we got to make sure that we're taking care of ourselves in the process. So first, we're going to talk about this idea of our attitudes towards suicide and towards people with suicidal thoughts. So please feel free to either, just kind of raise your hand or unmute and say, or add in the chat. But like, what are some thoughts that people have about suicide and about treating people with suicide? What kind of comes up for people? Yeah, Sarah.
The first thing I think of is suicide for people. It comes up as like the only option,
Yeah.
and based on kind of like wearing blinders in a way and kind of staying alone inside their own head in regards to those thoughts make it real. Um,
Yeah, for sure.
and so even when I'm doing like my typical intake and asking those questions, even if there isn't a concern initially, I always like to kind of give that kind of psychoeducation behind my own interpretation of what it's like to have some suicidal ideation or thoughts and why it is so important to share what is going on, because then when you share it outside of yourself, it makes it real, and then it actually can even open up other options.
Yeah.
And so that's kind of what comes to mind when I think of
Yeah. Yeah, I love that viewpoint, right? Like you're in this echo chamber in your own mind, but if you kind of get outside of yourself, then it loosens things up. Yeah, I love that. Any other like thoughts that come up with people or opinions? Like I mean, it can even be things that we know are even in the general population, even if we don't agree with them, right? Like sometimes in the general population, suicide is seen as like a selfish thing or like an immoral thing, things like that. Some of us may have our own feelings about treating people with suicidal thoughts. Like maybe we feel afraid, like maybe some of us find ourselves when we ask our clients about suicidality, maybe we find ourselves internally sort of like crossing our fingers and hoping they say no because we're kind of scared if they do. Yeah, in the chat here, I'm seeing clinicians can feel afraid to discuss it or fear of triggering the client. Yeah, that's a big fear that can come up of like, well, if I say it, is it going to put into their minds, right? And we know that's not the case, but it's a very natural kind of fear and kind of worry. Yeah. So, you know, we all have these innate feelings and attitudes that are going to come up when we are dealing with suicidal persons. And the thing
Hello.
that Oh, sorry. I
Oh, yeah?
can't see anymore, but I'm hearing somebody. Please go ahead and feel free to share.
Oh, hey. Um, I haven't had a sorry. I haven't had a chance. I got it. I got the quote. Hold on one second.
I'm not sure if if you're just accidentally off mute or if you're sharing in the group. Maybe accidentally off mute. Sounds good. Okay. Um, so anyways, like we were saying, we all have our own attitudes about suicide that like we even maybe even before we got into the field, certain things we had. And really we're going to talk about some of the attitudes we might need to like unlearn as well as some of the attitudes we need to learn. But really a great place to start is thinking about we are there to focus on what is clinically right for our patients while doing really good practice, right? We want to strive for what we'd call like a concerned alertness. I'm not dismissive, right? Like I'm not saying, oh, well, they haven't acted on the suicidal thoughts yet, so they probably won't. But I'm also not an alarmist, right? I think it's as Sarah was sharing, um, we want to encourage our clients to talk out loud about these things. We don't want to be over alarmist. And when they like say, oh yeah, I'm having suicidal thoughts, really, kind of overreact either. So we want to kind of toe that line. And we really have to try to understand that our role is to do the best we can to keep them safe and keep their autonomy when that is possible, right? So there's this great quote I'd like us all to talk about or just to observe and look at by Jobs. He is the person that created the CAM suicide assessment, which is like a college based suicide assessment. But the quote is, oops. While we can never guarantee a non-fatal outcome, we can nevertheless provide the best possible clinical care to every patient, including those with suicidal thoughts. And this is a huge thing that we have to kind of reckon with. Like the reality is we cannot guarantee a non-fatal outcome in all situations. And that's a really hard thing to accept. I think in the medical model, it's a little bit easier for us to accept, right? Like doctors can't save every patient. That's just the reality. That's the reality for us too, right? That doesn't mean that it's something that we should be afraid of or have a pessimistic attitude, but we want to have a really kind of a radical acceptance attitude around that. So with that, some of the attitudes that we might want to try to be like unlearning if they're not helpful would be like an over preference for hospitalization. So I want to be clear, hospitalization is absolutely necessary in certain cases for our clients. Like sometimes we just have to do it and it is what it is. However, we don't want to just jump there initially, right? A lot of times as clinicians, we might feel more comfortable personally with our clients being hospitalized because then it's like, hey, I don't have to worry about it anymore. I know that somebody's going to be with them 24/7. However, from the client's experience, unfortunately, despite best efforts by providers, hospitalization can be pretty traumatizing, right? You got to think about it. They're going to this place they've never been before. They're working with therapists and nurses and staff that they don't know. They usually don't have access to their phones, so they're cut off from their support system. They don't get to keep their own shoes. They don't get to keep their own clothes, and they don't get to leave whenever they want. Right. So that can be a really difficult experience for clients to have. So when possible, we always want to try to keep them safe and keep them in their supportive environment. Again, that's not always possible, but when we can, we really want to do that. So we don't want to just jump straight to hospitalization in our minds. We might also need to unlearn information about no suicide contracts. So for those of us who aren't familiar, these are pretty popular for a time, especially in like inpatient settings. It's basically a contract drawn up between the patient or the client and like the nursing staff or the therapist, basically saying, hey, I agree, I'm not going to harm myself while I'm on the unit. Unfortunately, despite like the draw for this, because it can feel good of like, oh yeah, okay, we're on the same page, like they're not going to hurt themselves, like we're both in agreement. Unfortunately, the research just does not support that these are effective tools. So we want to try to unlearn leaning on those things. We want to work on safety plans, but no suicide contracts themselves, they just don't have good efficacy. We also want to really make sure we're not using like an overly controlling, a paternalistic, or a fear-driven approach, right? Like I'm not ever telling my clients, you need to do this. It's like we are very collaboratively and together creating a safety plan that feels actionable and like helpful for them. Um, so that's a really important thing for us to be thinking about. Again, I think as clinicians, we might feel fearful, so we want to try to control the situation, but ultimately we're a lot more successful when we collaborate with our clients. We also might need to unlearn any beliefs we may hold that suicidality is a linear process. So sometimes we might think of it as, okay, they're feeling down and then they have passive suicidal thoughts, and then they have active, then they have plans, and then they start, preparing for the plans, and then they act on them. That does happen sometimes. However, that's oftentimes not the trajectory for a lot of people. Sometimes they go from having passive plans to acting on them within a matter of like hours or days. Sometimes they skip steps, sometimes they bop around to different steps. Just because somebody's having passive SI doesn't mean that we should write it off, that it's not a big deal, right? Similarly, though, even if somebody is getting to that point of like having thoughts of plans, that doesn't mean that we can't also bring it back down that chain and like, make it more manageable as well. And finally, we have to reckon with the fact that unfortunately, suicidality is really unpredictable. And the reality is, as clinicians, we're just not as good at predicting it as we would like to be. I mean, about half of suicides occur in people that are not in a high risk group or people that denied having suicidal thoughts the last time they were seen by a provider. And we don't reckon with this to, again, be like fearful, but just to have a healthy respect for the fact that suicidality is somewhat unpredictable. And we just kind of have to account for that. So now that we kind of have a sense of some of the attitudes we might need to adopt or unlearn, let's kind of go into some of our risk and protective factors. So our risk factors, a lot of these are going to be familiar to you guys. And, I will say these are not an exhaustive list, but these are some of the big ones. Risk factors for attempting suicide would be having previous attempts. Do they have comorbid other mental illnesses? Are they currently going through legal issues or criminal issues? Do they have issues with substance use, hopelessness? That's a really, really big one. Are they a victim of violence? Have they perpetrated violence? Do they have a history of somebody in their close circle who's committed suicide or died by suicide, rather, excuse me? Are they more likely to be socially isolated? Do they have other physical illnesses like a chronic pain, like a cancer diagnosis, something like that? And then is there a current or prior history of adverse childhood experiences or ACEs? On the other side, in terms of protective factors, are they actively making future plans? And a quick word here on making future plans. The more specific, rich in detail, and committed the client seems to these plans, the better. So it's just qualitatively different for somebody to say, yeah, I'm with my partner. I've been thinking about like proposing. We just got pre-approved for a mortgage. Like we're trying to move forward with our lives. Like I really want this. That's qualitatively different than a client saying, I mean, I don't know, I guess one day I want to get married and be happy. Right. So like the more rich in detail, the more realistic, the more committed they are to the plan. That's a much better indicator of a protective factor than when it's just kind of like basic or formulaic. Other protective factors include hope for the future. Do they have self-efficacy in a problem area? I mean, a great thing is a lot of times they do just by the fact that like our clients are coming to therapy for help. So like they're like, hey, I have a problem. I need to figure out a way to get some help. Um, Other protective factors are if people have responsibilities to kids, pets, families. Pets is a really, really big one that can be super helpful to focus on because even if they're socially isolated or if they have a difficult family dynamic, if they do have pets, that's a really big one. Again, ideally, if they're embedded in a protective or social network or family, it can be a protective factor if they have like a religious belief that suicide is something they can't do. And do they show just a general like attachment to life? So it's important for us to know these risk factors because these are things that we're going to be thinking about when we are dealing with risk management, right? If understanding, are they more likely than not to have these suicidal thoughts? Because they have a lot of risk factors. What are the things that make us more confident that they may be able to manage these suicidal thoughts? Like we can think about protective factors as let's use these things they have to try to keep them safe. So as we start to talk about risk management, there's many things that we need to be thinking about. So we're thinking about anticipating if there's going to be suicidality, detecting it, and figuring out how to address it right from the get-go, right? So this is always something that we ask in our first intakes, of course, and then ongoing as well. So, we want to understand and feel really comfortable with how to ask about suicidality and what do we do when somebody says, yeah, I am feeling suicidal, right? Um, we may have different levels of comfort with asking about suicidality, right? Like it's something we deal with every day, but it's still a really hard thing. So I always find it helpful to hear examples of how other people do it. And of course, we have to find our own style and what works for us. But just as an example, for me, whenever I'm talking about suicidality, I say to my clients, with everything that's been going on for you, with everything that's been on your plate lately, what, if any, thoughts of wanting to hurt or kill yourself have been coming up for you lately? Um, and even when they say no, I'm not having any suicidal thoughts, I always find it super important to follow up with asking, well, have you ever had these thoughts come up for you in the past? Because it can kind of be surprising how many people will say, no, I'm not having them right now. But then when you follow up, they say, well, yeah, I mean, I've had them before. I've had attempts in the past. Like I've had inpatient history. So really getting as full of a picture as you can. From there, excuse me, when our clients do endorse suicidality, they say, yeah, I am having suicidal thoughts. And then we have to kind of ask some follow-ups, right? Of, okay, how often are you having these thoughts? How intense are they when you have them? I always like to know, like, what do you do when you have the thoughts? Do you just wait for them to go away, or do you use distraction? Do you call a friend? What would you do if they got more intense than they are now? That's a great place to start talking about safety planning from the get-go of, would you call your family? Would you call a crisis line? Like how would you imagine yourself handling this? A question I always like to ask my clients too when they endorse suicidality that I find is a very like gives me really rich answers is when you have suicidal thoughts, what do they sound like? Right? Because having the thought of I just can't do this anymore or I don't care if I don't wake up is qualitatively different than the thoughts sounding like, I'm having thoughts that I want to die and, I want to die by this time, or if this doesn't happen, I'm going to kill myself. Like those are just qualitatively very different. So those are all things that I like to think about. From there, again, like I said, we want to be aware of our risk and protective factors. We may want to also use some assessments. As I said, unfortunately, as flawed human beings, as clinicians, we're not as good at predicting suicidality as we would like to be. So using objective measures and screeners and assessments can really help augment our clinical decision making. So some popular ones would be like the Ask Suicide Screening Questionnaire, um, the Columbia Suicide Severity Rating Scale, the CSSRS, and we actually have access to this in Valent as a measure, so that's a really great tool. The CAMS I mentioned a little bit earlier, it's specifically formulated for college students, but it actually can be a super great tool to use for a wide variety of populations. So these are the things we're starting to think about. When we talk about risk management too, we also really need to make sure that we know the laws in our jurisdiction. Right? So the law is the floor of what we must do for our clients. So like if they meet this certain threshold and there really is this imminent danger, we do need to break confidentiality and get them to the hospital and make sure that they're going to be safe. However, there are so many other safety measures that we can do before that to try to keep them out of the hospital. And that's what we're going to be talking about today. But that being said, it's super important to know what the rules are and be really confident that you know how to apply them. I find that this is the most helpful when clients are worried. Like we probably all experience this. A lot of times clients are worried of, well, if I tell you I have suicidal thoughts, do I have to go to the hospital? Right? And we want to be very confident in like where that line is when we have to do it and when we don't. And that's a hard thing because it can be pretty gray. But I always say to my clients, and this is what personally works for me, is I try to give them a sense of control. I'm like, hey, we never have to go to the hospital as long as you and I can come up with a plan that we both feel confident can keep you safe at home. So like that's up to you. As long as you can work with me and we can achieve that, we do not have to go to the hospital. We'd only ever have to go if that's not a possibility. So really giving them a big sense of control. Very briefly, I'll just give an example of the laws in my own state that I practice in, so Pennsylvania. So in Pennsylvania, we have what's called like a 302 or an involuntary commitment. And basically, we have to commit somebody when they're a danger to themselves or others based on behaviors in the last 30 days. So it's either if they haven't been able to take care of themselves without help so seriously that they would be injured or die within 30 days, or if a person has attempted suicide or made threats to attempt plus acts of furtherance, right? So obviously if somebody attempts, that's a little bit more clear cut, but we can see how gray it is with this other situation. Most of the time our clients are not coming to us saying, I'm going to kill myself and this is exactly how I'm going to do it. And I've already had access to lethal means or whatever. That's usually not happening. What usually happens is the client's like, I have suicidal thoughts and most of the time I don't want to act on them. And, I have looked things up on the internet, but I haven't like gone out and gotten anything. So it's a really big gray area. So it's tough. It really is quite challenging for us to assess and manage. But that's what we're going to be talking about now. So when we're doing risk management and safety planning, the first goal is always safety. It just has to be. At the end of the day, safety has to trump all. However, that doesn't mean we forget about autonomy and well-being. We really want to preserve autonomy and well-being as much as we possibly can, to really avoid traumatizing the client, to avoid, creating more risk for them, managing ruptures, things like that. So when I'm thinking about managing a suicidal client's feelings, first, I'm really thinking about how do I get my client through that acute, agitated, urgent phase of the suicidality. So as I think a lot of us have seen with our clients, SI can come in bouts, right? Where like something will happen that triggers it and it's really intense. And then it might go away for a little while. And then it might get really intense and go away. It can be cyclical, it can come in waves. The really dangerous place is whenever it's like that sense of like urgency, like I'm having intense thoughts of wanting to hurt or kill myself, and I feel like I have to do something about that. If we can get our clients through that urgent phase, if we can get them to wait that out long enough, the SI is going to come back down, right? Like that's almost always how it works. The body, the mind wants to reach equilibrium. It's not going to want to sustain that level of distress. So let's get them through that really acute stage. So the way that we can do that is by making those resources readily available to them of like, okay, I'm having intense suicidal thoughts. What do I do? I really enjoy and I find it helpful to create like a paper safety plan with my clients collaboratively. Because a lot of times it's like they're in distress, so they can just pull that piece of paper out and they're like, oh yeah, like me and Sarah are already decided all these things that I can do in this exact moment to keep myself safe. And we're providing these solutions in advance so they don't have to think about them, right? Because whenever we are having like intense suicidal thoughts, we cannot think clearly. Like that's just not a realistically going to happen. So that's why we decide on what we'll do before we're even feeling suicidal. I really think a lot about um, how we can create friction between our clients and lethal means or acts of furtherance, right? So first off, we have to also, of course, understand what kind of access to lethal means do they have, right? So when people have specific plans, that's a helpful thing to like assess. So if they have plans of using like a sharp object, okay, we think about that. However, clients don't always have concrete plans, as evidenced by this discussion of suicidality not being linear. So sometimes they have SI and no plan, but then all of a sudden they kind of do. So it's really important for us to think like, okay, do you have guns in the home? Most homes have sharp objects, so like how accessible are those? A lot of our clients are on medication that can be lethal in high doses, right? So like how much medication do you have? Like how do you control that? Like understanding all of these things is really important. Because once we understand that, we can figure out ways to put friction between the client and those lethal means. And so what I mean by that is just making it harder for them to access them so that they're less likely to be able to access and use these lethal means during that acute urgent phase of the suicidality. So an example of this might be like with guns. So, obviously it depends on the community you're in. In the community I work, lots of people have guns. Um, we can totally ask our clients to give them to somebody else. And that can be great if they're willing to do that, but a lot of times people aren't, right? So I don't insist on that, right? Because I want us to be collaborative. If somebody doesn't want to give their gun to somebody else, okay. Maybe let's talk about, certainly can we store our guns in a locked way, in a locked box without ammunition, like not loaded. So that's a really big step. If we can also store like our ammunition in a different part of the house, that's even better, right? So think about this. A client's having these thoughts, they go to get their lethal means. They have to go upstairs, they have to get their key, they have to unlock it, they have to get that gun, then they have to go back down to a different part of the house, get the ammunition, load the gun. We have just created so many moments of friction between them and the lethal means for them to have that second thought of, hey, do I really want to do this? Right. And that is kind of all we're trying to achieve here to try to keep them as safe as we can. In this process, we really want to focus on empowering our patients and clients to be as involved as possible, right? Like I said, I always make these safety plans with my clients. They are not prescriptive at all. They look completely different depending on who I'm talking to and what works for them and what doesn't. Another huge part of risk management for me, I think, is consulting with other providers. I cannot overemphasize that. Consult, consult, consult. Even if you feel like, yeah, I feel pretty good about how I handled that, like just double check, run it by somebody else, get another set of eyes on it. That's super important. It can be helpful too to double check with our clients, rephrase our questions, get secondary sources from family if we can, use those assessments we talked about. The final piece that's so, so important is documentation, right? So we want to document so, so carefully. Because here's the thing, there is liability in what we do. That's just a reality. We're not responsible for our clients, but we are responsible to them. And so we want to make sure we're protected, of course. However, when we are making clinical decisions based out of fear of liability or fear of litigation, we're no longer making good clinical choices, right? We have to be focused first and foremost on what's best for the client. Documentation is where we protect ourselves because good clinical decision making is what protects us, right? And documenting is what protects us. So, whenever I have a pretty intense risk level that I'm trying to manage, I'm really thinking about documenting what did I do? What was my rationale? Why did I do that? Why did I not do something else that I could have done? Did I consult? If so, with who? What did they say? What did we agree on? So really making sure you have a nice full record of your clinical thought process. Because again, good clinical decision making plus really good documenting, that's what keeps us safe as clinicians. And very briefly, because I do want to save some time for questions and some time to talk about our vignette, but very quickly, let's just talk about I just want to give everybody an example of like what a paper safety plan could look like. So for me, I go through with clients, like, let's talk about what are your warning signs that you need to use this plan of, maybe you're feeling more hopeless than normal. Maybe you're feeling trapped. Maybe you're feeling like, emotionally painful. So cueing yourself, hey, I need to use this when I feel X, Y, and Z. Then we want to talk about coping skills they can do all on their own that don't require other people. This is where it's super unique to the client. For some people, it's playing that one video game, or it's going for a walk, or it's going to the library, or it's doing grounding, whatever. We want to talk about people, places, or settings that are a good distraction for them. So again, maybe they go to the library when they're feeling lonely, or maybe like their one friend is like, always fun. They want to be with them. We also want to talk about people, places, or social settings we should avoid. If there's family members that are super triggering, if substance use is an issue, we want to avoid going out to the bars, things like that. We also identify together who are the people in your life that you could really ask for help from. If you were in it and you needed somebody, who would you call? And like put their phone numbers down on paper. That's always super helpful too. We also want to look at like what are some professionals or agencies that they can contact during a crisis. And this is something that it's important for us to be aware of like our own limitations. Like I tell my clients, just because of the nature of the place that I work and my own lifestyle, like I check my emails during the day. I don't check them after hours. I don't check them on the weekends. So if you need imminent help, we need to look at using like a mobile crisis center or a mobile crisis line. Like I tell my clients, hey, if you need an extra appointment, email me. Like we will make it happen. But if you are imminently in danger, we got to use some of these other resources. I also talk to my clients again about what we can do to make their environment safer. Like I talked about, this is where we're thinking about creating friction between them and things that are dangerous. The last thing I always put in my safety plans that I have found to be very helpful and I've had to use on several occasions is steps that we agree upon together if my client doesn't show up for treatment. So if I have a client that has some pretty intense SI that we manage and they just don't show up, like I'm scared, I'm worried, right? And so I like to agree with them in advance what we're going to do. So like maybe I'll call them and I'll email them. And then maybe if I can't get a hold of them, maybe I'll call their emergency contact. If I can't get a hold of them or they don't know where they are, maybe we call for like mobile crisis to do a wellness check. But again, these are things that me and the client agree on. So we're both on the same page of like, hey, you don't come, this is what happens. Again, I know I'm kind of burning through this. I really appreciate everybody sticking with me. I know it's a lot, but like we could spend like so many hours on this, let alone one. So we're going to try to get through what we can. Once we've created this wonderful safety plan for our clients and they're feeling good, we're feeling good, we've done awesome clinical work, we're patting ourselves on the back. Now it's time, and not just at the end throughout, but we also got to be thinking about like ourselves and our own self-care, right? So burnout in our profession is huge, right? Between 21 and 61% of mental health practitioners experience burnout. That's huge, right? And it's no surprise we're doing such difficult work. It makes sense. But we are our most important clinical therapeutic tool. We got to find ways to protect it. So let's briefly just talk about self-care because I think in our field we talk about like this amorphous idea of self-care a lot, but it's like, what does that actually mean? Let's drill down on that. So self-care is about engaging behaviors that maintain our physical, emotional, and cognitive and spiritual well-being. We have to have a caring attitude towards ourselves, and we have to reflect on what we need. So one model of self-care that I like to kind of think about for myself is there's like 6 pillars of self-care. So there's awareness, balance, flexibility, as well as physical health, social support, and spirituality. So briefly, we'll kind of go through these. The idea of awareness is kind of understanding what does it mean to be a mental health provider and reflecting on our own experiences and our needs, right? So we have to think, each week, am I feeling drained? Did I notice myself getting a little bit more distracted during my sessions? If so, why? Like, how demanding was my caseload this week? We can really try to boost our self-awareness by focusing on mindfulness, on journaling, like scheduling a check-in time for ourselves, things like that. We also want to focus on trying to find a sense of balance in life, balance between our personal lives and our professional lives. It's important to consider, though, balance is not a destination, unfortunately. It's something we strive towards, but we don't live in balance all the time. So we just want to use our awareness to make sure like we're checking and making sure we're striving for balance, right? So at work, maybe we make sure we have manageable caseloads. Maybe we make sure we engage in a variety of clinical activities. So maybe we do therapy, but we also teach, or we do supervision or outreach or whatever. Maybe we need to be mindful of our breaks. For some of us, an hour break in the middle of the day works. For other people, it's 15 minutes 4 times a day. In our personal lives too, we have to make sure we have time for our leisure and hobbies. We have to have non-work related passions, right? Like a lot of us are so passionate about mental health, which is amazing, but we have other passions too. We're three-dimensional people. We need to seek support from our loved ones and have that work-life boundary. We also need to be flexible, right? As mental health providers, I mean, we see so much challenge. We have to adapt to so much, changing caseloads, changes in clients' lives, changes globally, like the impact of like the pandemic, about like election stress, things like that. So the more flexible we can be, the better. So we have to meet ourselves with self-compassion. We have to let go of ideas of perfectionism. We also want to think about our physical health, of course. We all know this is hard. Therapy can be a very sedentary job. Between sessions, maybe at most we have like 7 minutes to run to the bathroom, to get a drink, to do some notes. So we got to figure out what works for us. Maybe we use that 7 minutes to walk around. Maybe we make sure we get our exercise in before we get to work, whatever that may be. Social support is important professionally as well as personally. So professionally, get some really good supervision, peer consultation, maybe be a part of APA or your state psychological organization. Have a mentor, stay connected to your former professors and like peer students as well from grad school. Of course, we need to have our personal life supports too, our friends, our families, maybe even our own personal therapy, depending on the season of life we're in. And then finally, spirituality can be a really helpful domain of wellness, right? So it's just having a higher sense of meaning or purpose. There's this great quote from some two researchers, Norcross and Guy, that says, "To be present at the moment of a significant insight or decision in the life of a client is a spiritual experience that connects the psychotherapist to the flow of life and creation." I think that's a great quote that really speaks to how I try to maintain a sense of spiritual wellness for myself in our work, is reminding myself how amazing it is what we do. And to be present in these moments is just huge. But it can also look like mindfulness. It can look like time in nature, prayer, gratitude, whatever it may be for you. So again, now that I've given you so much information to digest, I did want to try to kind of talk about it in a practical way if we can, and still leave time for some questions. I know we're getting tight here in these last 20 minutes. But I kind of have some vignettes for us, and I thought maybe we could talk about what comes up for us. So really what we're trying to do here is use this vignette to kind of practice what we've talked about today in terms of like, what does it actually look like for us to apply the skills of risk management, of, identifying protective and risk factors and starting to come up with like a risk management strategy. So for this vignette, Jane Doe is a 25-year-old single white female presenting with depression. She's been receiving a psychiatric medication from PCP for the last year, but has seen little improvement in mood symptoms. She endorsed suicidal thoughts without plan or intent a few times a week, which sound like, "I wish I wouldn't wake up tomorrow," or "I'd get hit by a bus on my way home." Again, we can use the chat, or we can use, just raise your hand, or just, start talking on mute. What more do we feel like we want to know here? What information are we looking for? And Jack, if you can help me with the chat on this one, I can't look at it without getting rid of the vignette that people might need to see.
Gotcha. Casey commented, "I'd ask if she communicated this to her PCP and how often/intensely she's experiencing these thoughts."
Yeah, for sure. Totally agree with that. Yeah, we want to make sure that the prescriber knows what's going on.
Callie said, asking about any past attempts.
Yep. Great
Callie
question.
said intensity of suicide ideation and duration of suicide ideation.
Mhm. Yep.
Got a lot here. I'm just going to read them off. What medication is it possibly affecting suicide ideation?
Yeah.
Has she ever had suicide ideation with a plan or intent? Does
Mhm.
she have access to weapons?
Yeah. Whoops. Yeah, exactly, right. A lot of those great questions and like asking about like what supports does she have, what risk factors should she have, all of that, right? So for the sake of time, I'll kind of give you our next piece of information that we have about Jane Doe. So Jane's currently unemployed. She reported losing her job due to receiving a DUI while driving home from a party 3 months ago. She denied drinking since that time. However, she endorsed issues falling asleep due to racing thoughts about the mistakes she made and how this will impact her future. She reported presenting to therapy after her friends noticed the change in her mood and behavior and encouraged her to seek support. She currently resides in an apartment with her dog, who she's very connected to. She's very close to her two siblings, but is estranged from her parents due to a difficult childhood with them. What else do we need to know? And what risk and protective factors are we seeing here? And again, people can feel free just to unmute and say, or you can put it in the chat and Jack will call it out.
In terms of protective factors, we have embedded in social support.
Yep.
She has an animal to take care of.
Yep.
Again, strong connection with a dog. In terms of what more to know, does she have substance use history?
Yep.
Risk factors, she's unemployed.
Mm-hmm.
Someone's asking more information about difficult childhood, how that could be a risk factor.
Yep. Are there some
Ask
aces
about
there?
family history of substance use.
Mm-hmm. Yeah, exactly. Exactly. Yeah, even, and I don't think this is one of the ones we mentioned, but even issues with sleeping can sometimes be a risk factor. So we're also seeing that there where she's, having trouble falling asleep. So yeah, great identifying all of those. So a few sessions in, Jane admits that she's had thoughts of different plans, including walking into traffic, overdosing on medication, or hanging herself. She denied any acts of furtherance towards these plans. She continued to deny intent, citing her strong reason being her faith. The thoughts fluctuate in duration, frequency, and intensity, but sometimes they're quite upsetting to her. What are some thoughts that people are having on what a risk intervention or risk management plan could look like for Jane? And I know it might be hard not to be able to see, but I think I might stop sharing just in case anybody wants to unmute and discuss. Okay, let me look at the chat here. Oh, cool, lots of really good responses. Okay. Okay, yeah, so we're talking about we could tap into her spirituality. Is safety planning with her considered a risk intervention? Yes. Yeah, thanks for clarifying. Yeah, we're talking about risk intervention. It's like safety planning. Yeah, so we want to talk about who she could reach out to, what kind of like crisis support line she could call, who's a good person that distracts her, resources for support, assessing if she has a faith community, maybe a 12-step program if she's open. Yeah, that would be awesome, right? You can have a found community even if you don't have one naturally. Going for a walk with her dog when it's really severe. I like that idea, right? Because it's getting her out of the house, it's moving her environments, but it's also connecting her to this animal that she has a connection to and responsibility for. We might be doing some behavioral activation. Yeah, Catherine's saying, let's talk about limiting access to her medications to avoid overdosing. I think that's a super important piece. How can we create friction between her and her medication? Can we, if maybe we can get a smaller dosage from her PCP, like refilling it more often. If we can't do that, maybe we can, have like a daily pill box that's like just a couple days worth of pills, and then maybe she puts the bottle of more pills, somewhere really difficult to access. Not impossible, but again, we're just creating friction. That's part of like making her environment safer. Again, like we said, we as the clinician and her may want to discuss what we would do if she just like didn't show up for treatment. Maybe we would even want to maybe we'd even want to try to consult with her PCP if we could get a release of information from Jane. Yeah, how about some self-compassion as an intervention? I love that, right? Like, how do we meet ourselves with compassion when we're having suicidal thoughts? Because people really, a lot of times, feel a lot of shame and pain from just experiencing suicidality at all. So yeah, I like that a lot. Carly's talking about maybe we can explore medication alternatives, 100%, right? Like there could be a medication that does not agree with her. Maybe she's been previously misdiagnosed, you know, and that may be what's causing the wrong medication to be not working for her. Like if she's, you know, has bipolar and is being prescribed an SSRI, for example. Really, really important things for us to consider. Yeah, so I love a lot of these ideas. You know, as we can see, it's such a three-dimensional thing. We want to be thinking about so many aspects of the person because that's how we can kind of keep them safe. Amanda's sharing, create more of a routine in self-care, going to church weekly, talking with her siblings at certain times. Yeah, I really like that. Having yourself to be accountable, like, hey, I call my sister on Tuesdays at 5, and like if I don't call her, she's gonna be worried about me. That's a really great thing. Any other thoughts before we maybe like transition to some questions? Okay. Again, I really appreciate everybody not only taking their time, but sticking with me through this. I know it was so much information, but I really wanted to get a lot in, but also allow us to have times um, for questions at the end. And in the slides, I know I didn't show it, but we have like some resources as well. If we want to go back to that at some point, I can even share that real quick, just so it's on the recording if people want to check that out. Yeah, so here are some of the resources for us. But yeah, let's make sure that we have some times for questions here. And again, like I said, you can either put it in the chat or put it in, or just unmute or raise your hand. And we have a question about if we're going to share these slides. Yes, we're going to share the slides, and the recordings will be available as well. So in our last like 10 minutes here, what, if any, questions or any like thoughts that people want to share of things that work for them when they're managing suicidal clients and things like that?
Just quickly, maybe while people are coming up with questions, I just want to explain. I mentioned this in the chat before, but there will be a post test that'll be posted to Relias that will go with the slide deck. And I just want to make sure that you guys complete that. That way, we don't have any certification for continued education credits yet. But if we do get certification, one of the requirements will be that you've completed the post test. So it may be up even to this time tomorrow, but sometime in the next week or so, it should be up there. And I do believe all of the previous slide decks and post tests are up as well. I know we had some trouble with that. Some people couldn't find them. So I think they should all be up there now. And this one will come up in the next week. So just make sure you guys get that done. That way, if we do get certified, you can get credit for that.
Cool, thanks, Jack. And I'm seeing two comments in, or a couple comments in the chat. One from Carly is about I try to note countertransference and regulate myself to help the client regulate. I think that's awesome. If we can be that calming, secure presence while they're, you know, kind of telling us about something that's really vulnerable and really difficult for them, we're modeling that and we're kind of like sharing that calming space. So I think that's a great one. Shannon's asking a great question of how do we approach situations where a client does not want to answer questions around suicidality, right? Like that's a super stressful situation. You're like asking them and they're outright saying, I'm not answering that, which, you know, that kind of puts our antennas up of like, well, there's probably something there if they don't want to answer. And so a lot of times in that situation, it's not even so much that I try to focus on like, well, you have to tell me, but I'm more like, well, can we talk about why you don't want to tell me that or why you don't want to talk about it? A lot of times I find in this case, clients are fearful of what's going to happen to them if they disclose SI. And so that's when I start to talk about what I mentioned before, when it's like, know your laws, know your regulations. That's when I try to give them that sense of control. Like, hey, we don't have to go to the hospital. Like, we're here to keep you safe. Like, they obviously want to be in treatment. I mean, assuming they're in an involuntary outpatient setting, of course, but like they want to be in treatment, so they have some desire to keep themselves safe and well. And so if we can just assure them that like they're not going to be in trouble, we're not like automatically calling 911, a lot of times that makes people willing to open up and talk to us. Another question from Sarah is about, would it be helpful for us to establish an agency-approved overall safety plan? Yeah, I think that could be a really awesome thing for us to explore. Maybe that's something we can look into, as well as even like kind of crowdsourcing ideas from everybody about what they have found works for them. Because as I said, that safety plan I shared with you, that's personally what I use. That's what works for me. But I think we all have a lot of different ones that work for us. Another comment is, I would be mindful when making suggestions or planning to take into account that people in distress are often overwhelmed. Slowing things down can be very helpful. With the example of Jane, I would have asked, what would suicide solve? And also what distresses you about these thoughts? Yeah, I love that. I think that's such a great point, right? Of their mind is racing. Like even the fact that they just disclose this to you, like, they might have tunnel vision, like their ears are ringing, like they're stressed. So being mindful of that, really slowing things down, getting them comfortable talking about these thoughts and what they mean for them and why they're having them is really important. There's this great question from the CAM suicide assessment model that I think kind of speaks to this point. And the question in it says, if we could change one thing about your life that would make you no longer suicidal, what would that be? And I find that question to be really helpful, even if you're not following the CAMS model strictly, just asking that question. Because a lot of times it's amazing what it'll be, right? It might be something like, if I could just get a handle on my racing thoughts, right? Or if I could just have some idea of where to go from here or what it could look like to get better, that would make me no longer suicidal. So like that, it's kind of like that solutions focused magic question kind of idea. It gives us such a great direction to go that's meaningful to the client. Denise is saying, I think as a clinician, it's important to remember that if a client has suicidal thoughts, asking them the thoughts will not make it worse. 100%, right? Like their thoughts are already there. You're not putting it into their head. Nobody has ever said, oh, wow, I never thought about that, but I will now, right? And it can be a relief for us as clinicians to be talking about it and to be creating a space where like it's okay and it's encouraged to talk about it. So yeah, great point. Other questions, other thoughts of what works for us? Yeah, psychoeducation is great too. Thoughts about what works for us, other like kind of fears, or even just us kind of having to sit with the reality that like we can't always keep our clients 100% safe 100% of the time.
I just want to mention, I think some of the kind of societal norms that we place around death in general makes it very, can make it a very shameful experience to individuals who are having these thoughts.
100%.
And so I think, like, when I mentioned psychoeducation, I think I also mentioned kind of this normalizing around death in general and about it being a part of life and being a part of like this journey, I think kind of also helps with building that foundation of trust and maybe even creating a dialogue or a opening for people to feel like they can confide information around what they might be going to when it comes to death. Because one of the greatest fears I would think in my own personal experience is that fear of like what a horrible person I am because I have these thoughts. And thinking about death is a part of life, right? So like I just kind of wanted to share that it's interesting how it causes this reaction in us as human beings that is kind of unexplainable, but and at the same time, we automatically label it with it's something bad or wrong when we know that death isn't bad or wrong. It's more so whether it's coming from a place that's bad and wrong, right? Like
Yeah.
whether it's based, yeah. So I don't know if I'm being really clear, but I guess I just kind of want to share. Okay.
Yeah, no, I think that's great because I think also that's like that's a great way, even if somebody's not actively suicidal, I think taking that approach there that you do is a great way to create a safe space that if those thoughts ever were to occur, we can talk about it. We're just like demystifying death in general, right? And there's some existential kind of pieces to that, right? And we're kind of like, hey, we can talk about this stuff in here and it's okay. It's not shameful. It's not bad. It makes sense, right? It's like you're in pain, you're suffering. I can understand why these thoughts are coming up, but let's just figure out how to deal with them.
Right. Thank you.
Yeah. I know we're in our last few minutes here. I'm gonna stay on right up until 1 because I do have another appointment at 1, but people, everybody, I appreciate everybody coming, so feel free to sign off now if you don't have any other questions, but I will stay on till 1 o'clock. But like do your self-care, take your bathroom breaks, do your stuff. But like I said, I'll be on here until right up till 1. Yeah, thanks everybody for attending too.
Dr. Fox, while I have you here for like a minute or two, I have a client whose a son died by suicide.
Oh.
So do you have any resources that you know of for
Is it-
that specific grief reaction?
Let me think about it. Denise, I think I have your email. So let me think
Yeah.
about it and kind of like follow up with you about that. But yeah, that is such a like
Yeah.
definitely feeling a lot of empathy for her. 'Cause that's like such a difficult space
Yeah.
to be in.
Yeah.
Family member, let alone like a child. But yeah,
Yeah.
let me look and see if I have anything. But
Okay.
yeah, look specifically for that grief process.
All right, that'd be great.
Awesome.
you.
Yeah, thanks.
Bye-bye.
Bye.
Thank you, Dr. Fox. That was a wonderful presentation. I think people seem to like it. Very informative. So I appreciate all the hard work you put into it. And
Yeah.
Appreciate
I'm
all your
not
help.
sure I'll be able to make the one on Monday. I'll give you an update maybe later this weekend, if that's okay. But
Yeah, that's no problem. Yeah, it actually it's easier than I thought to like go out of like sharing. So
okay,
no
great.
problem at all
Awesome.
either way. All right, everybody. Again, thank you so much for attending. I'm gonna go ahead and end the meeting here. And we will go from there. Actually, Jack, real quick, do I have to do anything with the recording, or I guess it'll just go on my computer maybe, and I'll send it to you?
I believe it'll go on your computer. You might get an email with it. I don't think there's anything you have to do right now. You can just end
Okay.
the meeting.
All right, awesome. Thanks, everybody. Have a great rest of your day. Bye-bye. I don't know if the 3 people that are still on are able to get out of the meeting. Unfortunately, it doesn't look like I can edit. Oh, actually, I'm just going to remove you all from there. So thank you again.